Hello, so we are going to be doing our focus assessment comparison on asthma. In this video, we have Jannat Abdallah, Maya Alcala, Kylie Brown, and Jenny Lee. These are the lovely people that are going to be presenting this topic to you guys. So in this video, we are going to be going over what asthma is exactly. We're going to be talking about subjective and objective data that you would see in the respiratory assessment, so that you have a little bit of information before we just dive into the topic of asthma. We're going to be talking about normal findings in asthma, abnormal findings that you would see, so that you really be able to tell the difference of whether they actually have asthma or not. We hope you guys enjoyed this video. Please remember, you guys may use this as a study aid, but please do not disseminate any of this content elsewhere. Thank you guys. What is asthma? Asthma is an intermittent, reversible, obstructive disease of the lungs. It is also the leading severe chronic illness in children. It's usually due to allergies, IgE, and hypersensitivity reaction. This can be genetic or environmental, including allergies, viral infections, parasympathetic stimulation, meds, psych, or even exercise.
For subjective data of respiratory assessment, it is important to assess breathing effort, pattern, and factors related to breathing. The listeners would ask questions such as, have you experienced difficulty breathing? Do you have labored breathing? Do you have hard time breathing when you are lying down? Do you have cough or sputum? Or do you have any chest pain? Moreover to the breathing, it is also important to go over the patient's lifestyle, which relates to the respiratory. Questions like, do you exercise regularly? Do you take any medications? Do you do nicotine, vaping, drugs? Are you exposed to environmental irritants such as paint or asbestos? Would be used to determine whether their lifestyle or living environment affect their breathing. For smokers, it is important to calculate the pack year, which is done by multiplying number of years of smoking and number of packs per day. First step of objective data is inspection. Nurse would inspect skin tone for cyanosis or pallor, thorax for midline trachea, symmetry, use of accessory muscle, rib slope, shape and position of sternum, anterior-posterior and lateral diameter ratio, breathing effort, pattern and rate, and chest expansion. Second step of objective data is palpation. Nurse would palpate the lungs area with finger pads and palms. It is important to palpate for any kind of pain, crepitus, and chest expansion. For chest expansion, nurse would place hands on posterior thorax at level of 10th vertebra, gently press skin between thumbs and have patient take deep breath, and you would observe the thumb movement. The third step of objective data is auscultation. It is important to inform patients that every time you feel my stethoscope move, take a deep breath in and out through your mouth. If you get dizzy, please breathe normally and let me know. Nurse would auscultate 4 points on anterior, 6 points on posterior, and 1 under the right arm. Using diaphragm of stethoscope, exert firm pressure over intercostal space. Listen for 2 full breaths and compare symmetrical sides of thorax while moving stethoscope from apex to base of lungs. You should avoid bone and breast tissue. Should begin at apex, compare left and right and left down to base of each lung.
Now we're going to go ahead and discuss some of the normal findings when doing a respiratory assessment. And this assessment can be seen on 3 locations, so the anterior thorax, lateral thorax, and posterior thorax. So starting with the anterior thorax, we're looking for the position of the trachea, which is typically midline, respiratory patterns that are 12 to 20 breaths per minute, with breathing that is even and unlabored, chest symmetry that is equal, intercostal spaces that are even and relaxed, and the position of the sternum is leveled with the ribs. Now, in the lateral thorax, we're looking at anterior posterior to lateral diameter, which typically has a ratio of 1 to 2. Now, continuing with normal findings, but for the posterior thorax, we're looking at chest symmetry that is equal, intercostal spaces that are even and relaxed, a rib slope that is less than 90 degrees, and a chest expansion that is 3 inches with deep inspirations. Next, we're going to go ahead and talk about some of the abnormal findings. So starting again with the anterior thorax, we're looking at the position of the trachea, and it can be deviated right or left. Respiratory patterns are less than 12 breaths per minute or greater than 12 breaths per minute. Breathing can be uneven, labored, shallow, or deep. Chest symmetry is unequal. Intercostal spaces are bulging or retracting, and the position of the sternum is depressed or projecting. Now, as far as the lateral thorax, looking at anterior posterior to lateral diameter, we can see greater than 1 to 2 ratio or less than a 1 to 2 ratio. And typically in patients with emphysema, we see a 1 to 1 ratio, which is also known as a barrel chest, which can be seen in the picture to the right. Continuing with abnormal findings, but for the posterior thorax, we're looking at the chest symmetry that is unequal, intercostal spaces that are bulging or retracting, rib slope that is horizontal or greater than equal to 90 degrees, and chest expansion that is less than 3 inches deep with inspirations, or a decreased chest expansion, which is typically seen in COPD patients. And another thing that I mentioned in abnormal findings were lung sounds, which include wheezing, stridor, bronchi, pleural rub, and crackles.
The most common findings expected with asthma are high-pitched wheezes, a cough that can be dry or productive, chest tightness, and dyspnea. Dyspnea means shortness of breath, and sometimes people who are experiencing an asthma attack can experience this so severely that they can hardly speak. They may also experience an acute airway obstruction, which can cause them to start using their accessory muscles to breathe. As an airway obstruction becomes more serious, you may also observe sternocleidomastoid and supraclavicular contractions, which is a sign that the patient is experiencing an increased respiratory effort. You may also see nasal flaring, and as the airway obstruction worsens, you may not be able to hear breath sounds anymore. Another sign of asthma would be the patient is in a tripod position. This means that they lean forward when sitting or standing, usually with their elbows on their knees, or if standing, they might lean on something in front of them like a table.